Okay, it's 9 o'clock. I think we can go ahead and get started. Aloha, everyone, and welcome to the SEOW quarterly meeting. My name is Micah Thompson, and I am a graduate research assistant on the State Epidemiological Outcomes Workgroup team from the University of Hawaii at Manoa, along with the State Community Partnerships Workgroup team. We hope everyone is having a great week so far. To start off the meeting, we will introduce our speakers and have a quick overview of the agenda. We'll start off with a welcome and an overview of the Hawaii Strategic Prevention Framework Partnerships for Success Project, the State Epidemiological Outcomes Workgroup, and the State Community Partnerships Workgroup. We are very excited to have Dr. Tanya Laurie St. John present the latest trends in Hawaii alcohol and substance use from the BRFSS, ERVIS, and PRAMS. Dr. Laurie St. John is an associate specialist at UH Manoa and the principal investigator of the Hawaii Health Data Warehouse in the Thompson School of Social Work and Public Health. She has a master's in public health from the University of Connecticut and a PhD in epidemiology from the University of Hawaii. She has extensive work experience with public health surveillance data and a passion for making that data accessible and available to the public. She is also the co-editor of the Hawaii Journal of Health and Social Welfare. This presentation will be followed by a brief Q&A and a 10-minute break. After the break, Laura Johnston and Dr. Michael Phillips will present polysubstance use and adverse childhood experiences in Hawaii, data from the 2020 Behavioral Risk Factor Surveillance System, or BRFSS. Laura Johnston is a policy research associate on the SEOW team and is also a doctoral student in sociology at UH Manoa. Dr. Phillips' research broadly focuses on how motivational approaches can be used for health behavior change. He's an associate specialist at UH Manoa in the Office of Public Health Studies. He's currently the principal investigator for the SEOW and also a co-investigator on a recent NIH-funded study to develop a mobile intervention for alcohol and cannabis co-use to reduce negative consequences, delivered via a smartphone app to young adults on Oahu. This presentation will also be followed by a brief Q&A and then closing remarks. So let's begin with an overview of the Hawaii Strategic Prevention Framework Partnerships for Success. The SEOW is part of the Hawaii Strategic Prevention Framework Partnerships for Success, or SPF-PFS, which is a federal grant funded by the Substance Abuse and Mental Health Services Administration, or SAMHSA. The purpose of the SPF-PFS is to strengthen and enhance Hawaii's prevention system to promote well-being and reduce the impact of alcohol and substance use among persons aged 9 through 20 in Hawaii's communities. The SEOW is a partnership between the Department of Health's Alcohol and Drug Abuse Division, or ADAD, the University of Hawaii, and interested community stakeholders. The SEOW has been providing epidemiological services to ADAD since 2006 and collects, analyzes, and reports substance use incidence and prevalence, as well as provides technical assistance and training for state and community stakeholders. The SEOW comprises of researchers, epidemiologists, data managers, and other professionals involved in research, data collection, and utilization pertaining to alcohol, substance use, mental health, and well-being. For the SEOW, the core team produces the Hawaii State Epidemiological Profile for alcohol and drug use, using the latest available data from diverse data sources to profile the current substance use situation locally. We also conduct these quarterly meetings where individuals and organizations have the opportunity to share their substance use related data. As part of the SPF-PFS, the State Community Partnerships Workgroup, or SCPW, supports academic and community partnerships that increase the capacity of the substance abuse prevention system to address local needs. The SCPW achieves this by conducting applied research which addresses alcohol and substance use among high-risk populations. In this way, the SCPW supports the goal of the SPF-PFS. So that was a quick background on the SPF-PFS project, the SEOW, and SCPW. There are just a few reminders we want to go over before we get started. We are using the Zoom webinar format, which may look a little different from the Zoom meeting format that you may be used to. Attendees are muted and videos are off. The presenters and hosts are not able to see attendees, and attendees cannot see themselves. If you have questions, please send them through the Q&A feature located at the bottom middle of your Zoom window. You do not have to wait until the end of the presentation to submit your questions or comments. Please send them at any time and we'll review them at the end of the presentation. If you'd like to wait until the larger discussion at the end of each presentation, that's totally fine too. So without further ado, I would like to go ahead and hand it over to Dr. Laurie St. John.
All righty, can you guys see my screen?
Yes.
Perfect, okay. Well, good morning and thank you for having me. It's a pleasure to be here with this group and to talk a little bit about the latest trends. We've just finished. I'm Tanya Lowry St. John and I am with the Hawaii Health Data Warehouse, and we have just finished the loads of the 2021 BRFSS, URBIS, and PRAMS data. And so we'll talk a little bit about those data sources today, and I'll be talking about what kind of information we have about alcohol and drug use in those sources, and then how you can access that information. So I did I was thinking about it, it's a little bit of a tricky thing. We'll talk a little bit about what the latest trends are, but really what I want to focus on is how to find that for yourself so that you can really cover your area of interest. So for those of you who are not super familiar, the Hawaii Health Data Warehouse, or HHDW, is a collaboration between UH Manoa Office of Public Health Studies and the Hawaii State Department of Health. We were created back in 2001 to manage the health data for the state and to provide that data to the public in a user-friendly format. We've been through some different formats over the years, and we now have our latest 2 platforms, and we'll be going over those today. And one of the things that we are charged to do is to track Hawaii's progress towards the Healthy People targets. And we provide this data, our emphasis is to provide Hawaii-specific data from state and national data sets. So today I'm going to talk a little bit about 3 of our sources of data: the Behavioral Risk Factor Surveillance System, or BRFSS. Some people call it the BRFSS. The BRFSS people do not like it when you call it the BRFSS. I was just at their national conference, just a little FYI, I thought that was pretty funny. The Youth Risk Behavior Surveillance System, also sometimes called the YRBS or YRBSS, or the URBIS. And then the Pregnancy Risk Assessment and Monitoring System, which goes by PRAMS, and they're okay with that. We're going to review the latest from each of those data sets, and I'm going to demonstrate how to find more in-depth Hawaii data on alcohol and substance use using our systems. Okay, so in the HHDW, we have these main data sets. So the BRFSS, the PRAMS, the YRBS, the Youth Tobacco Survey, and the Vital Statistics. And today we're just going to be talking about those first 3, but we do have more data than that in the warehouse. And just for those, just a really quick overview to remind you about these surveys and how they're done and who is surveyed by each one. The Behavior Risk Factor Surveillance System is a collaboration. All of these are collaborations between the Centers for Disease Control and Prevention and the Department of Health. They are state-run surveys that are supported by the CDC. The BRFSS has been going on since 1984. Hawaii joined in '86. It's currently done in all 50 states, the District of Columbia, and 3 U.S. territories. It is a telephone survey, so it uses both landlines and cell phone samples. Nationally, they survey about 400,000 adults, and here in Hawaii, we do about 7,800 adults each year. They cover a wide variety of health topics that are really there to assess the health status, health-related risk behaviors, chronic conditions, and use of preventive services among adults in the United States. And so again, we were focusing on the alcohol use and tobacco and other drug use. In our system, we have that under sort of the area for BRFSS under substance use is our category that we use, and these are the subcategories of data that we have there. The next one is the Pregnancy Risk Assessment and Monitoring System, or PRAMS. And again, it's that collaboration model. It was started in 1987. Hawaii has been collecting data since 1999. It is a written or telephone survey of about 1,400 people who have recently given birth in the state of Hawaii. And this is an interesting survey in that it's sort of dual, that the information comes from self-reported information from the person who gave birth who filled out the survey, and then also from that data is linked to the birth certificate for information about the actual the birth itself and the infant that was born. In our system, we have the information divided up between, looks like, there we go, okay, since it is designed to cover information that's before, during, and after pregnancy, our alcohol, tobacco, and drug use sections are going to be located in those 3 different places within our system. The next one is the Youth Risk Behavior Survey, and the Youth Risk Behavior Survey, again, it's a collaboration format. There's 2 surveys that are actually done each time. There is a high school survey, so that's grades 9 through 12, and a middle school survey in grades 6 through 8. They're actually slightly different surveys because they're cognitively able to answer different questions on a good repeat basis sort of thing. So they're slightly different for the middle school and the high school. And in Hawaii, it is a written survey. In the last 2 administrations, so 2021 and 2023, we've also added an online component for schools that they want to do it online. And we survey about 6,000 kids in public schools across the state for middle and high school each administration. So this is done on odd years, whereas the BRFSS and the PRAMs are done every year. The topics for the YRBS include all kinds of health risk behaviors that contribute to the leading causes of death and disability among youth and among young adults. And so for the purposes of this group, that would be interesting was probably going to be the alcohol use and then the drug use, possibly tobacco use. We divide up our data into categories when we're putting it out there for people to look at. So these would be our overall categories, and this would be the substance use category, subcategories that would probably be the most interest to this group. Just I like to kind of throw this slide in here as sort of an overview for the data sets to remind people. So then we're looking at BRFSS data. It's, a little under 8,000 adults each year, and we collect data on a lower geography level. We collect the data actually at zip code level, and then we aggregate them up into not just state and county, but community, school, complex area, and primary care service area. And I'll be showing you some maps of those as part of the demo. And then the Youth Risk Behavior Survey, we survey, again, the middle and the high school students. It's about 12,000 of both. The data is available down to the county level. And then for the PRAMS data, it's about 1,400 people who gave birth. And the people tend to be a reproductive age, obviously. And then that data is only the county. So both these have county level data, and this is going to have sub-county level data. Okay, that's the boring stuff. So if you, but it is the details, because I believe, the devil's always in the details when you're looking at data. When you want to know where you can find this data for Hawaii, this is where we come in as the Hawaii Health Data Warehouse. This is literally our job. And we have 2 sites that we use to be able to get this data out. We'll go over a little bit, some views of both of those today in this demo. We have the Hawaii Health Matters.org site, and that has curated indicators. So it has over 800 indicators of community health from 50 different data sources. So you'll see those 3 data sources that we're focusing on today, but we also pulled in Hawaii specific data from other sources. For example, the National Survey of Drug Use and Health, we pull in quite a bit of data from there as well, which might be helpful for you. And then we have the HHDW.org site, and that is where we keep only the data that we manage for the Department of Health. So those are from our central data sources, and you can access data in here through our community reports, health topics, build your own reports. We have those 5 data sources, and we'll be focusing on health topics and build your own reports today. All right, so for the Youth Risk Behavior Survey, we'll start with the youngest. So to remind you, that data is available at state and county. It's at middle school and high school. We have the detailed information that we make available to you for your own analysis by year, grade, race, ethnicity, Hispanic or Latino, sexual orientation by sex, transgender, and sexual or gender minority status. Got a little asterisk here because in 2021, so one of the things to know is that they actually changed the way that they asked the sexual orientation question. In HHDW, our practice is that we put up indicators once there's 2 years of data, because once you start to slice and dice, otherwise you end up having to suppress so much. And so because of that, our sexual orientation data for 2021 is not available. The 2023 data just went out into the field. That survey was collected, and we are expecting that data back hopefully by later this year. And so hopefully by early next year, we will have that out, and then we'll have our new indicators based on the way the new questions are asked for 2021 and 2022. 23. The other thing that I want to note is that, and we have a lot about this in our data release notes, is that the 2021 data should be interpreted with caution. And that's because two main reasons. One is that we generally ask people about what they did in the last 12 months or so forth. And a lot of these kids were at home. They were at home for the last 2 years because of the pandemic. So their experiences are entirely different from their experiences of their peers in the past. And the second is that we normally administer the survey in the spring. But because of we were trying to keep on that 2021 to keep in our odd year, we had to administer in the fall because not all the kids were back in the spring of 2021. And so the kids are a little bit younger in 2021, right? As a senior in high school, it'd be the beginning of your senior year as opposed to towards your end of your senior year and so forth throughout the grades. So the responses may be a little bit different. So we advise everybody to interpret that with caution. Okay. These are all of the indicators that we have for YRBS in HHDW. We do also have the ability to do a data request, and I can show you where to find that information as well. But these are all of the indicators that we have. And today we're just going to focus really briefly on this current drinkers among high school students. And so if we look here, when you can run our data, we have the data in the system. Our data runs from 2000 through now 2021. So you can look at the data over time to look at current alcohol use by year. You can also then look at the data by sex. So you can see, like, for example, there are females are actually in high school more likely to report current alcohol use than males, and that's been a persistent trend across time. You can also then change the way that the data is displayed. So if you prefer to look at it by these horizontal bar graphs with labels, that is also offered. That is also an option for you in this system. We always display the confidence intervals so that you can then compare reliably across data points and across years. You can look at the data here by county. So this is an example of one of our county maps. If this was the live system, when you hover over it, you can quickly then go and see what corresponds to what. We also have the data in the system by grade. So here it is by grade. So you can see then this is 2017, 2019, and 2021. So all of the trends are pretty much the same. There was a big difference between alcohol use by grade in 11th to 12th grade back in 2017. The difference is much less pronounced in 2021, but you can see then that obviously that the rates are much lower in 2021 than they were in the previous years, right? You can also look at it by race ethnicity. So then this is the 3 years of data, again, across all the different race ethnicities. You can combine years of data, and we'll be doing that and other things. So if you want to combine years to have more stable estimates, the system allows you to do that as well. And then we also have, you can look at the data for here. I just went ahead because I'm focusing on that 2021 most recent data. This is the data by transgender status, because that does exist for the 3. I went ahead and aggregated 3 years of data for this so that you can get a better idea and a more stable estimate, because our transgender population tends to be smaller. But you can see that in terms of current drinking, among those who are transgender, it was this youth that identify as transgender, it was 30.8%. As you hover over in the system, you would get those confidence intervals compared to the students that identified as cisgender, and then those that are not sure. In our system, especially among the students, we keep those not sures separated, and we use them. Oftentimes other researchers will throw out not sure, don't know, but in this case, because of where they are developmentally and so forth, we think they're an important population to keep an eye on, and they're also tend to be almost all indicators at higher risk than the cisgender counterparts. And then I went ahead and pulled up a bunch of information from a bunch of different slides and put it together for looking at ever drug use by by drug type, and then also by school type. So we have our high school here in blue. So whoever used marijuana, it's 21.2% compared to 5% among middle school students. And this is our 2021 data. And this is prescription pain medication, methamphetamines, cocaine, ever used a needle to inject illegal drugs. And then we have ecstasy, heroin, and illicit drug use. In this case, these were not asked of the middle school students, so that's why they're blank. But this is a composite measure of all of these among the high school students of any illicit drug use. Did you want me to answer the questions live as we go or hold them to the end?
Oh, that's completely up to you.
Okay. Maybe I will answer at the end, just so we make sure we get through. Okay. So then the next one we have is our PRAMS data. So again, that's available by the state and county geographies, and you have detailed information by years, mother's age group, race, ethnicity, marital status, education, poverty level, and if they were on WIC during their pregnancy. And then we also have the infant's sex, infant's gestational age, and birth weight. So you can look at all of those sort of outcome measures in with these indicators. The alcohol and drug use indicators we have for this group, these are the ones for before pregnancy, during pregnancy, and after pregnancy. And we're going to go ahead and focus just really quickly so you can see how they would look in the system on the alcohol drink in the past 3 months of pregnancy. So again, you can run that data by across all of the years, and this is one where we get the data from 2000 through 2021. So you can see it this way. If you want to do a different kind of graph, you can configure those in the system. So looking at trends over time in terms of women that or people who gave birth who are reporting drinking in the last 3 months of pregnancy. We also have the information available by county. So you can see here Maui County was quite a bit higher than the others, but you can look at the confidence intervals and see that they overlap. So you may want to aggregate multiple years of data to confirm whether or not the drinking is actually higher among people who gave birth in Maui County. You can look at it by mother's age group. So this is our standard age group that we have in this system. You can also look at the data by race ethnicity. So this is our race ethnicity, our standard race ethnicity. We call that the DOH race ethnicity. This data can also be looked at by the more granular program race ethnicity. So I went ahead and ran it this way as well. And for this one, I added 3 years of data because once you get into the smaller program groups, your numbers can be smaller, but then that way you might be able to look at, you can aggregate multiple years of data if you're interested in populations that are smaller within Hawaii, like Korean or Samoan, Chinese, and so forth. So this can be helpful for folks as well. And then also we have the data available by education. So you can look at our drinking during the last 3 months of pregnancy by education. And it was highest among those with college, 4 years of college or more. But again, you can look and it's not significantly different because if you look at the way the confidence intervals overlap. And then we can look at the data also by poverty level. So there's a bunch of different ways you can slice and dice the data depending on the population that you're interested in. And then just because to sort of keep a theme here, I took a look at the marijuana use during pregnancy because that's one of the ones that we are asking on a regular basis. And you can look here, we had the data for the state, Hawaii County, Honolulu County, Kauai County, and Maui County. And this is one of those questions that we asked before pregnancy. So to be using marijuana before pregnancy, during pregnancy, and then after pregnancy. And for more information about how each of these indicators are defined, you can actually hover in the site. I'll show you how to do that. And they're also in the different data reports for the actual question wordings. But sort of give you an idea of some of the flavor of the data that you can pull from the system. And then lastly, we'll look at the BRFSS data. So this is the one that we have available by a bunch of different geographies. We have both crude and age-adjusted rates within the system, which is really helpful when you are comparing different populations to at least take out the age factor since so much of health is age-related. And then we have the information again by year, sex, race, ethnicity, Hispanic, or Latino. We have 5 different age grouping options that you can use to view your data. sexual orientation and gender, marital status, education, employment, income, poverty level, healthcare coverage, and health conditions or behaviors. So we can look at people who have diabetes, obesity, or have ever been diagnosed with cancer, current cigarette smokers, and people who meet physical activity recommendations. So you have the ability to sort of cross-tabulate some different health behaviors. This is all of the data that we have available on our system right now for our alcohol, prescription medication, and marijuana. The marijuana data is new in 2021 because it was collected in 2020 and 2021. I think it's also collected in 2022, so we'll be updating that over time. And we'll just take a quick look here at alcohol, heavy or binge drinking. So as a reminder, heavy drinking among women is more than 7 drinks in a week. And among men, it's more than 14 drinks in a week. And binge drinking is more than 5 drinks on one occasion among men and more than 4 drinks among one occasion among women. So again, in the system, you can quickly look at the data over time. You might notice that this data is just from 2011 forward, and that's because there was a major change in how the BRFSS was conducted from the beginning until then. So it's not advisable to trend past data, so we just do it from 2011 to 2021. And then you could also, again, look at that data by sex. So you can see here there's a significant difference in drinking among men compared to women, and that is persistent, but does seem to be trending downward over time. The data is available, as we mentioned, by county, by island. And so in this case, I will point out that I went ahead and aggregated 3 years of data because we're going to get down to some smaller sizes, but we have so much data that you can do that, which is a real benefit of the system. So you can go down by island, by community, by primary care service area, and then by school complex, which would be our most granular. So you can kind of really get into sort of getting at what's happening, not just on a countywide basis, but get down really closer into your community as to what's going on. You can look again at the data by it. All data can be viewed by 2 dimensions in the system. So here we are looking at it by age and sex. So you can see, we saw before that there was a higher drinking among males than females pretty much across the board. This also carries across the board, not for the 18 to 24-year-olds. These guys are not significantly different, but once you pass that, it's significantly higher among men. We can look at the data by race ethnicity. So again, these are our DOH, our standard race ethnicity categories. We can go in and look at the data by program race ethnicity. Since we collect a lot of data here, we do collect more detailed information, which we roll up into the DOH race ethnicity. And in our system, if you want to go ahead and sort it to make it easier for you to look at, you can do that as well. So again, like if you're really interested in the Korean population, you saw you can get PRAMS data at that level. You can get BRFSS data at that level. It depends on the data source as to how granular you can get, but our program race ethnicity is always going to be the most granular data we have available. Okay, and then again, we can look at the data by our sexual orientation and gender identity. So here we have straight males and straight females compared to gay, bisexual, or something else. They can identify as just something else, so that's why we're using that term. Males and lesbian, bisexual, or something else females. So you can see, while there's no difference in heavy drinking between straight males and gay, bisexual, or something else males, there is quite a bit of a difference between straight females and lesbian, bisexual, or something else females. So you can use that information in the system. And then we can also look at it among the transgender population. So among those who identify as transgender, heavy drinking is about 14.7% compared to those who do not identify as transgender. And then I did just throw this one together for you too. It's a combination of data from the source. So for those who are interested in looking at the age-adjusted BRFSS data for the last 2 years for marijuana use. And so this is if you used it any of the last 30 days, which we call a current use. So this is the data for the state, Hawaii County, Honolulu County, Kauai, and then Maui County. And this would be frequent use, so it would be 20 or more of the past 30 days for the state, for Hawaii County, for Honolulu County, and Kauai County and Maui County. So you can see, that for both Hawaii and Maui are quite a bit higher than Honolulu County, for example. Okay, so then where can I find this data for myself so I can do all my own searches and so forth? Again, we have our Hawaii Health Matters site and our hhdw.org site. And we come to hhdw.org. This will be our home page. I just want to point this out before we go into the system. We always have the ability to quickly go over to Hawaii Health Matters, or you can go into the Build Your Own Report if you know exactly what you want to do. For more information about how to use the site, we have a how to use section, and we also have training resources, and we have embedded videos around the site, so I'll show those to you. Also, I want to remind you that we have our news and announcements section down below. So this is where we're going to put in our most recent data. We're going to advertise our coffee break. So every month we have a coffee break where we do a skill building session about how to use and access and the data within our system. And so our next one is coming up July 11th, and it's going to be on the 2021 PRAMS release. We also try to spotlight local Hawaii data sources in our Hawaii Health Matters and here on HHDW. So if you are doing a report and you're releasing it and you'd like to get some more publicity, please send it on to us. We will add it to our reference library so it can be combined with other things, but we can also add it to both of these sites so that people can see it more. And then we advertise it on our social media as well. So in Hawaii Health Matters, there's 3 ways to access data: community reports, health topics, and build your own report. And we're going to focus on health topics and build your own report. And I think I'm going to switch to the live demo now. Okay, so here we are on the site. And so we're going to come up to here to health topics. And this is going to give you we have our data divided up into 20 different health topics. So if you know what you're interested in, but you don't know who has data on what, you can go ahead and click on this one. So we'll go ahead and click on alcohol. Oh, wait, before I go that, I just want to point out, we do have a brief overview video for this whole section and an in-depth webinar. So if you need more information, please refer back to those. So we come in here into our health topics, and we generally say you read on the left and you click on the right. So for all of our health topics, we have information about it, what's important, why it's known, who's at risk, how to reduce that risk, publications that can be helpful for you on that, and then also resources that are available to you. And then here on our left-hand side, we're going to do our right-hand side, we're going to do our clicking. So we have the ability we have indicator reports within the system. But for example, if I'm interested in teen drinking, I can go ahead and click on one of these dashboards, and this will bring you over to our Hawaii Health Matters site, which will pull in data both that we have on the state level from our site, also from other data sources. So you can see here, we've got information about adolescent alcohol risk perception, binge drinking, alcohol use, and so forth. And we have, this site is a little bit more curated. It gives you the data in sort of with little icons to let you know how to interpret it. We have a legend on how to interpret those icons. And you can go in and click on any one of these. So for example, if I clicked on adolescent risk perception, to get a more detailed report about what we know about that, which will give you information about why it's important, trends over time, where the data source is, and then a bunch of other indicators and reports that can be helpful. So if you give us one of your reports, we put them in here, and then that can get linked to other data sources, which can be really helpful for folks. Okay, so those will be our health indicators dashboards. You also can come here to our customizable reports. And then we have this last one with this how it's tracked. These are other local and national data sources to track alcohol. So for example, here, if we came to our BRFSS data, we can see that here we have the indicators that we have within the system. And we've been looking at heavy or binge drinking. So we could go ahead and click on that. And this brings you to our standard data report so that now you can build your own report within the system. So this is our data use agreement, you would click I agree, and then now you can go through and work with the system. Our standard report is for the state for the last 3 years. So this is our heavy or binge drinking for the last 3 years. And scrolling down, we also give that full data table. So you'll always have the point estimate, the upper and lower confidence interval, the count, so how many this is. So in 2021, 18.2% of adults reported heavy or binge drinking. That's the lower and the upper confidence interval. So that's about 195,400 adults within the state. We round this because it is an estimate, but it gives you some really important information that you can use as you're writing for grants or trying to write documents demonstrating need. As you're scrolling down, if you decide you're in the wrong data set, you can click here to go to a different data set. If you want to change your health topics, you can click here to go back to the health topics. And in our technical notes, we will have that question wording, right? So then how do we define what a drink is? How are those questions asked? And what we use there. And then again, we talk about the weighting and then how to cite the data and so forth. So this is this can be super helpful for you if you want to then go ahead and then do your own analysis. You come up here and you modify the query. And this is where you can go through and you can select if you want to know people maybe who didn't heavy or binge drink. You can change your time period. You can change your geographic area that you're looking at, the age group. So those are the different age groups we have. The sex, demographic characteristics, and then our other health conditions. We generally tell people that those first different steps are there to help you refine or to filter your query. So what exactly you want to look at. And then this last step allows you to display. So you can decide that if I'm interested, for example, in looking at data by island, and maybe I really just want to know what we have on Kauai Island, I can limit that to Kauai Island. So now if I go ahead and click the data for the year, I will get submit, and then I will now be able to look at, this is 3 years worth of data, and this is what the data is for Kauai Island. And so you can go through and click and so forth and create your own reports in this system. And if you're coming back here and you want to change your indicator, we go back to select a new indicator, and that brings us to the behavior risk factor surveillance system page, all of the different groups, and we can go through and look at all of the different indicators that are available. Select if you want crude versus age adjusted. When you're ever having a question about what these are in the system, you can go ahead and click on the little question mark, and that will let you know how the indicator is defined. If you have questions about crude versus age adjusted, that is there as well. Okay, so I'm going to quickly shift back and Jake's make a quick plug for it's not letting me, there it is. All right, do that. No. I'm trying to show you guys my. Oh, that's weird. Sorry, folks. I was trying to quick show you my last slide that is going to be on. Can you see my screen?
Yes, we can see it now.
Okay, sorry about that. Close your eyes while I make you sick. Okay, so just to remind you then that we have our monthly webinars, which is our coffee break series, and we're going to be doing PRAMs coming up on July 11th. We've done the recent YRBS and BRFSS coffee break, so more in depth on those, and those are available on our YouTube channel. Remind you to sign up for our newsletter, and then I will be happy to answer any questions that you guys have. But I hope this was helpful. I know it was super fast, and then just leaving you all my contact information as well.
Thank you, Tanya. We are now moving on to questions. It looks like we have a few already, but if you haven't already, please type any questions or comments you had about the presentation using the Q&A feature, or you can raise your hand, I can unmute you, or we can also use the Zoom chat if you wish.
So the first one was about incidence data for substance use disorders in our state. That is, I think you probably want to be looking at NSDA data, but I'm going to defer to Michael on that one. But for, because you would need to have both use and then ill-adapted use. We have a little bit of information about that in the craft for the YRBS that was asked a couple of years, but that's probably going to be a NSDA question.
Yeah, that's a NSDA question.
Yeah, and the next one, and we have a little bit of information about that in Hawaii Health Matters, but that would be a NSDA question. And the next one is, I'm wondering if PRAMS and BRFSS data is collected to reflect our diverse communities. And is it collected through a health equity lens? So the PRAMS and the BRFSS are the people who are selected to take the survey are randomly selected, and they are, but we do oversampling on the neighbor islands in order to be able to develop standard estimates, and the data is weighted to represent the Hawaii population. But in terms of being collected in multiple languages, I think it's just English and Spanish, that would be because it's a national survey, and it is done, but one of the strengths would be is that it is done the same year after year. So at least in terms of trends and so forth, it's good. But in terms of would it be the best survey to find out really what's going on among the Chuukese population? No, because they're going to be a small population, and you're going to want to use that to create your overall view and then do your more in-depth studies with unique populations within the state. Okay, and then the next question is the BRFSS missing private school data. Yes, currently the YRBS is done in the public schools, public non-charter schools, and it is collected for middle and high school only. It is not cognitively tested for elementary school students. While many states do the high school YRBS, not as many do the middle school YRBS. There's also a national survey that's a part of it for the high school level, so it gives us national comparison data, but there's no elementary school level survey for this. It's not recommended by the CDC, I'm thinking, because the kids have to be asked themselves what's going on, and so you're going to get into reading level issues would be my guess. But I agree with you, vaping and drinking and starting to talk about that in an elementary school population can be definite, would be a definite, I could see how it would be a need, but right now it's just for middle school and high school, and it's only public non-charter schools. And then the next question is, can the YRBS data be seen at the school complex level? And the answer to that is no. And the reason is because it's not sampled at a school complex level. It's sampled to be able to give a representation of the different, of the state as a whole, and then of each of the counties is the way that the sampling is done. In order to survey at the school complex level, we would have to survey a lot more students. And this is sort of the county level estimate is what we've sort of come up with as the happy medium that gives folks enough without being overburdening the schools is where we're at. Though I can understand how that would be helpful at this point. We originally were just state, and then starting in 2015, it became state and county. So we did it at the county level. Okay. Any other questions for me? All right, then. Thank you.
Oh, it looks like there's one more question.
Oh. So the question is, how can we see data faster, not 2 years out? That's such a strain. I hear you. That's a frustration. One of the things that happens with actually, I can go back. One of the things that happens with the data is how it's collected. So for example, something like the BRFSS. The BRFSS data collection starts in January and it goes through December. So you have this whole year worth of data collection. And during that time, there is quality pieces and so forth done on the data, but it is not fully submitted for its final weighting and so forth to the CDC until probably about February or March of the following year. So if we're looking at the 2022 data, it probably went into the CDC final version between February and March of this year for 2023. The CDC takes the data for each of the states and has to go through a tremendous quality assurance and also weighting and so forth process. And then they begin to generate their specific indicators from the data, and then they begin to send those back out to the state, generally sometime in June or August between June and August, and it depends on the year. that years of data. So then the state BRFSS then has to look at all of the data and do their quality assurance and checks and go back and forth with the CDC on that. And then finally, sometime in like August or September, those data is then released to the states. At that point, then the state does their extra work and then hands it over to HHDW for us to be able to do our work and our data loading to be able to put it out. So it is about a year at least, and then that's in the very best case scenario. Sometimes the data doesn't get to the states until later and so forth. But we do appreciate that there's this desire to have it as soon as possible. And so we are working to try to increase our throughput to be able to make fewer delays on our end. With something like the PRAMS data, because it collects all the data in a birth for a year and the sample for December won't be drawn until March of the following year, then they still have to go through the data collection process. PRAMS tends to lag longer. The YRBS data is collected in the spring. In this case, what happened was that it wasn't collected until the fall of 2021. And so then we didn't get back to us until 2022. And we had to go through an approval process with the Department of Education and so forth prior to release. So that was your lag on that. So it's hard, but we are trying to work on our throughput. One of the other things that happens is create new indicators with data once we get 2 years of data. So we do have to do a pretty thorough review of the data every year and then meet with the different programs in the department to see how they want to divide those up. But we are working on trying to speed that up. But I hope that answers your question so you can kind of understand how long it is that it takes to get that data in the right form. Any other questions? I think Michael's answering the other one. Okay, great. Thanks very much.
All right, thank you so much, Dr. Laurie St. John. If there's no other questions at this time, I think Dr. Phillips is answering the last question there. We are now going to have a 10-minute break to give us some time to transition to the second half of our meeting. So feel free to stretch, relax, get some water. We'll see you back here at about 9:56. All right, welcome back, everyone. We are about to begin the second half of our quarterly meeting. Please join me in welcoming Laura Johnston and Dr. Michael Phillips.
Good morning. 1 minute while I just share my slides. Okay, there we go. My name is Laura Johnston. I'm going to get us started with polysubstance use and adverse childhood experiences in Hawaii and 7 other states. Data from the 2020 Behavioral Risk Factor Surveillance System, or BRFSS. So a quick overview. First, we're going to go through the background of what exactly adverse childhood experiences are and co and polysubstance use. Our objective and scope of our study, data source and methods. For our data source, we are using the 2020 Behavioral Risk Factor Surveillance System data. Key findings from 8 states, including Hawaii, and then findings specifically for Hawaii. And then we'll go through our implications and conclusions. So first, adverse childhood experiences. There are a range of negative life experiences that a person may encounter during childhood, so before the age of 18. And approximately 60% of US adults have endured at least one adverse childhood experience, or ACE. And approximately 1 in 6, or 16% of US adults have experienced 4 or more ACEs. And here to the right, we have just some examples of adverse childhood experiences. So it could include physical, emotional, or sexual abuse, neglect, or household challenges such as having a parent or caregiver with a mental illness in your household, or a parent that's experiencing domestic violence, or a parent or a caregiver, someone in the household who's incarcerated, for example. And this just shows how adverse childhood experiences can play out throughout a person's lifetime. leading to less quality of life and even a early death or less life expectancy. And we're going to be looking right here at the adoption of health risk behaviors related to ACEs, specifically substance use and abuse. So ACEs and substance use. So ACEs are positively correlated with nicotine, tobacco, alcohol, and cannabis use. The number of ACEs is related to early initiation and continued use of nicotine. And those who report ACEs are 2 to 4 times more likely to report problematic alcohol use. And those with higher ACE-related depressive symptoms are related to greater use of cannabis products to self-medicate. So this is where the research has been. It's focused largely on ACEs related to single substance use. So we wanted to look at ACEs and polysubstance use. So first off, polysubstance use is using 2 or more substances within a designated time frame. We are looking at within the past 30 days, but it could look at the time frame of the same week or even the same day. Nicotine, alcohol, and cannabis are most commonly used substances, and this includes substance use for polysubstance use. Simultaneous use, so it's kind of difficult to say with the BRFSS data whether or not the intoxication is overlapping. We know if they use these substances within the last 30 days, but we don't necessarily know if it was within the same event. And polysubstance use is related to greater negative consequences, so including legal implications, as well as it's just more difficult to treat a polysubstance use disorder versus a single substance use disorder. So a few studies have examined the association between ACEs and polysubstance use. One study that we're able to find was Shin and colleagues that found a higher number of ACEs was associated with greater co-use of nicotine, tobacco, and cannabis products. And polysubstance use that begins in adolescence is more likely to increase into adulthood, and those with a multiple substance use disorder, again, have a poorer prognosis compared to those with a single substance use disorder. So approximately 57.8% or almost 60% of Hawaii adults reported experiencing at least one ACE back in 2010. And having at least one ACE was more prevalent among Native Hawaiians and whites, those with less education, and those with lower household incomes. So our scope and objective. Our scope was focused on 2020 BRFSS data for ACEs and substance use for nicotine, alcohol, and cannabis. ACEs questions were asked in 2010, 2016, and 2020. And cannabis questions were asked in 2020 and 2021. So we focused on 2020 data to include both the ACEs and cannabis questions. And the primary objective was to investigate the occurrence of adverse childhood experiences in relation to alcohol, nicotine, cannabis, and poly-use of these 3 substances. We did examine single, co-use, and poly-use in Hawaii and 7 other states. So the 7 other states are Idaho, Kentucky, Mississippi, North Dakota, Rhode Island, Utah, and Wyoming. And we measured the cumulative effects of ACEs on substance use. So we did measure for 4 or more ACEs and that effect on substance use. So again, for our data source, we use the BRFSS data. It's a CDC annual national survey, as Dr. Lowry St. John went over in her presentation in much more detail. But it did consist of landline and cell phone surveys of adults aged 18 years and older. Prevalence data regarding health behaviors, medical conditions, risk behavior, and preventive health practices are included in the BRFSS. It has core modules, optional modules, and also state added questions. Data are weighted by the CDC to adjust for probabilities of selection based on 8 demographic variables using the ranking weight method. And just a quick COVID-19 disclaimer, because we're using 2020 data, It was the year of the pandemic, so our findings might not be generalizable to other years because of the pandemic year. So for our BRFSS items, for our ACE items, those were self-reported retrospective experiences before the age of 18. There were 11 ACE items in the survey. We condensed 3 sexual assault items to create 9 ACE items. And all ACE items were dichotomized to say ever versus never experienced. For our nicotine, tobacco, alcohol, and cannabis items, current use for alcohol and cannabis was asked, have you used it within the last 30 days? Current use of nicotine and tobacco was asked a little bit differently. It was asked as, do you use this every day, some days, or no days? And those items were combined to create the current cull and poly substance use variables. There was other covariates included, such as sex, race, ethnicity, education level, and age. Okay, and now I'm going to turn it over to Dr. Phillips to present the results and implications conclusion sections.
All right. Thanks, Laura. And so, switching over. So Laura did a nice job. She gave us kind of an overview of what the ACEs are, and then polysubstance use. And so I'm going to talk a little bit about some of the Hawaii data, and then also talk about some of the data in kind of relationship to the other states, and kind of look at doing some juxtapositioning to kind of see some of the differences. So starting off, let's look at, so we have the individual ACEs here on the left, and as we kind of look through, we can see those that are the most frequent. And so verbally abused, divorced parents, physically abused are those that are the most frequently experienced. We see also about 1 in 5, there was alcohol abuse in the home. And then if we go down, to the bottom, it's about 1 in 10 that experience familial incarceration. So a relative that was incarcerated as a child. Now, keep in mind, these are all of the respondents are adults over the age of 18, and they are responding about adverse childhood experiences before the age of 18. So that's something, keeping all of this kind of in perspective, and this is a retrospective account of these things. The other, and this is on the right, the pie chart, we can see the 4 or more is going to be one of the categories that we're going to, or the kind of groupings that we're going to talk more about, because in kind of the literature, this has been set as kind of being like this threshold of, this tipping point. And so this 4 or more, and so a lot of times they've taken this to be 4 or more of any of the grouping of the individual ACEs. And so we actually did some different analyses to look at none, the 1 to 3, ACEs experience, which 46% of the Hawaii respondents actually experienced 1 to 3 of the adverse childhood experiences before the age of 18, and 16% experienced 4 or more. And so then on the other side, here's some of the Hawaii frequency data for all of the respondents for any alcohol use. So it's close to 1 out of every 2 that are currently using some alcohol within the last 30 days. The same, and Laura talked about the current nicotine, tobacco. It's asked a little differently, but those that are using kind of in more recent, at least always or sometimes, is 17%. And then any cannabis use, So in the last 30 days is about 1 in 10 individuals. And so what we did is we did some analyses with this, similar to what others have looked at, for these single substances. And so we'll look at some of the ACEs in relationship to these single substances. But then we also looked at polysubstance use. And so when we start thinking about polysubstance use, I'll talk more about some of what that means, but using at least 2 of those substances or using all 3 of those. And so we have 3% of the respondents that were using alcohol, cannabis, and nicotine, and then 12% in the state that for the respondents that had been using at least 2. And this is all current use, within the last 30 days. So when they responded. So, and then on the other is at least one of those 3 substances, 41%. Okay, so then we also have data. So this is where, looking at the alignment of the other states that looked at adverse childhood experiences and also had a cannabis question on their BRFSS. So as Dr. Lowry St. John said, see, they don't love the BRFSS. I actually say BRFSS instead of BRFSS, which they probably don't like it even more. So I have to get out of that habit. So the BRFSS, the way in which it goes about, like, for those kind of optional models, not every state does the ACEs every year or every, we saw that, like, we haven't done for the state of Hawaii since 2016. And so 2020, we had the overlap with the cannabis question or cannabis questions, but we used just the one for the last 30-day use. And then the ACEs. And so for the 2020 year, there were 7 other states. And so we used that full data set to kind of do some juxtapositioning of some of this data. And so here's some of the breakdown for the number of ACEs. So you can see 4 or more is the 19%, 1 to 3 at the 44, and for none is 36. So, similar numbers, but Hawaii, we're a little lower for the number of ACEs that are kind of endured by the respondents. The substance use categories are similar as well. For polysubstance use, we see 36 or 3.67. Co-use is 13.89, so right around 14%. So these numbers are slightly higher than what we see within the state. Now, I'm not going to spend too much time going through the demographics, but here are all 8 states. And so we can see some of the numbers. So if you want to look at male-female kind of differences for the 4 or more ACEs, we can see that female is actually, for all 8 of these states, it's about 1 in 5 that are reporting 4 or more ACEs. And so we see that is higher than males. But on the polysubstance use, we see that males are reporting higher polysubstance use of all 3 of these substances. And so as we kind of look through, you can kind of just scan through some of those numbers. We also, so down at the bottom, we put in some of each of the states. And so we can see for the 4 or more, Hawaii has the lowest for that experience 4 or more of the adverse childhood experiences at 15.77. And then for polysubstance use, just right around that 2.73% kind of area. So with, I can move the chat out of my way here. I'll answer some of the questions then towards the end. And so that is something worth thinking about as the cigarettes, and so we'll chat. So the ACEs and substance use by single kind of any alcohol, any nicotine, and any cannabis, we then looked at individually by item. And this is kind of what gets done, in the literature of like looking at how all of these relate. And so this is for the Hawaii data. We see that for alcohol, we have close to 47% of individuals that respond that they have used alcohol in the last 30 days. And so when we start looking, there's a lot more variability here because 1 in 2 individuals are using alcohol. And then when we start looking at each of the individual ACEs, only some of these are related to any alcohol use. But this kind of also shifts a little bit when we look at all 8 states and have a bigger sample. But the variability here, we'll kind of talk about that a little bit when we look at the poly substance use. For the individuals, it's roughly around 10%, so 1 in 10 of the respondents that had been using cannabis in the last 30 days of some type of cannabis. And so we see that all of these items are related to cannabis use or recent cannabis use. And then out of the 17 that have used some type of nicotine or tobacco product, all of these items were related to tobacco use. So following along with the trends, in the literature, these items tend to be related to single kind of substance use of alcohol, cannabis, and tobacco. So some of the things that we were interested in is whether or not they're related to polysubstance use, and then kind of exploring that a little bit. And so just as a quick reminder, single use was just one of the 3 substances. So alcohol, so if they use just alcohol within the last 30 days, if they use just a nicotine tobacco product in the last or recent, and then if they just use cannabis in the last 30 days. And so that would be a single use if they use just one of those substances, in the kind of current period. Co-use would be recent use of at least 2 of these 3 substances. So they were co-using within the last 30 days. And Laura talked about, we don't know, based upon BRFSS questions, we don't know if those are simultaneous, if they're happening together, if there's overlapping intoxication, which there are kind of implications for that as well. And some of the literature out there that uses kind of other types of methodologies to look at that simultaneous use, looks at some of the, the increased kind of impact on the negative consequences. So, we could, and we have kind of done some looking a little bit at, well, those that are using, 20 or more days around certain substances, and then someone that's using alcohol 20 or more days, and someone that's using cannabis 20 or more days. And so it's likely that they're using those substances on the same day. But again, we can't kind of say for certain if there's overlapping intoxication in this. The last is all 3, the polysubstance use of all 3. And so this term polysubstance use gets used sometimes broadly to catch like multiple substances, and also sometimes for co-use. So just, know that sometimes it gets used as kind of a catch-all for more than one substance. So what we did was kind of looking at this idea around those that have never, or like, they're not currently using any of these 3 substances, those that are using at least 1, those that are using at least 2, and those that are using all 3, and how that relates to these adverse childhood experiences. And so we see that the single use, which thinking about like what the Hawaii data, the majority are using alcohol. And so this is like a big component of the single use here is there's a lot more that are using alcohol than cannabis or nicotine. The co-use and the poly use is, I think, the interesting kind of area that really is of note, and I kind of want to draw attention to, because this is current use of tobacco, nicotine product, and alcohol, or and cannabis, or some variation of two of these. And we see that the vast, there's only one that's not significant based upon the confidence intervals for co-use. And so all of these items tend to be related to co-use and poly-use. And this is kind of a big, like, okay, this is important to kind of consider when thinking about prevention aspects and how we think about risk factors, because this is clearly a risk factor that should be taken into account here and thought about, particularly for co and poly substance use. For those of you that are really interested in the actual odds ratios and looking at Hawaii versus the 7 other states, this is kind of what we're going to get ready. And I think it's visually a little bit more interesting, or easier to digest at times. So this is, if you like the numbers, here they are with the confidence intervals, but I'm going to kind of go through them visually with some forest plots. And so the things that we're going to kind of look at, though, is, so this is just a total number of the ACEs. So like, if you have 1, 2, 3, 4, 8, like this is just looking at how does the number of ACEs, kind of thinking from that 1 or 0 to 9, how does it relate to single use, co-use, poly-use compared to 0? So here we have, you know, all of these, both in Hawaii and in these 7 other states, are related. So the greater number of ACEs experienced or endured kind of during childhood are related to substance use of a single substance, and then co-use and poly-use of all 3. Then what we did was, because there's been this discussion of the 4 or more threshold as kind of like this tipping point, and so within the literature, they've done like some different kind of statistical analyses to look and see if, was it certain ones that are important? And well, it can, if there's only 1 or 2 of those, like, you know, they're not all of equal magnitude. And so if you experience like a familial kind of incarceration experience at the age of 4, well, that might have a greater kind of magnitude around one's experience as an adult. But what they've seen is you can kind of wash all that out just by looking at the number of. And so after you kind of reach that 4 or more, there's like this tip point. And so that's a lot of the those in the field have kind of looked at this 4 or more. And so we did the same thing to kind of look at and said, okay, so 1 to 3 ACEs versus someone that has not experienced any of those during childhood. And we see that for Hawaii and also 7 other states, there's a significant difference between those that, you know, have 1 to 3. And then we did the same thing with 4 or more versus none. And then we did this 4 or more versus 3, 2, 1 or none. And so we kind of looked at. And so here we'll see, here's the number of ACEs, kind of this cumulative effect, kind of, and this is related to co-use and poly-use here. Looking at the 1 to 3. So just experiencing 1 to 3 adverse childhood experiences compared to someone that didn't experience any adverse childhood experience, we see is being significant with single use. But like I want to draw the attention to the co-use and poly-use here, because, you know, this is where we start to see this kind of magnitude or this kind of build-up cumulative effect kind of happening. And so the 4 or more versus none for co-use and poly-use, we see kind of even kind of these increasing the likelihood of poly-use. And then the 4 or more versus less than 4. Well, so this is anyone that has experienced 4 or more, that threshold, versus someone that has experienced maybe some or none of these adverse childhood experiences. We still are seeing differences here in this kind of comparison. So this is the Hawaii data. So drawing in on the 4 or more, that threshold, and looking at how Hawaii compares to the 7 other states, we see that there's similarities and overlaps that there's, based upon what we had seen in the descriptives, the data for Hawaii is like, we don't have as many respondents that have experienced 4 or more, and we don't have the same level of polysubstance use, but it is still related to polysubstance use. And so experiencing 4 or more is related. And we also see the 4 or more is related to anyone that has experienced anything less than the 4 threshold. So looking at some of this and thinking about, well, okay, what are some of the conclusions around the data? Well, for one, looking at the Hawaii data, all the ACEs were related to nicotine and cannabis use, and also then a few of the alcohol kind of items. And so when we start to think about how adverse childhood experiences relate to substance use, and then how they relate to co-use and poly-use, we see that the ACEs tend to be associated with greater prevalence around the co and poly use, both in the state and in other states that collected this similar data. And then we have also this kind of last, the cumulative experience of this 4 or more, the multiple ACEs, this greater association being related. So that greater kind of magnitude as we cross that threshold of 4 or more increases the likelihood. And we see that, I didn't talk really about the odds ratios, but the likelihood, it gets very high. We're talking like 1,000% more at some of that level, to thinking about those that are using all 3 substances. So I mean, the magnitude is definitely kind of something to kind of take into consideration here. So some of the implications, multiple ACEs tend to have this kind of predictive quality, or at least associated with polysubstance use, because that's the other, is kind of keeping in mind that the limitation, which is we don't know, partly because we're not asking, or we don't have the data from the BRFSS that is talking about initiation of when these substances started to be used, at what age. And so, without knowing which of the adverse childhood experience, at what ages those were experienced, and when the substance use was initiated, it's hard to kind of say, but there is kind of this kind of predictive quality around polysubstance use in adulthood for current use of these 3, which tends to be related to negative consequences. And so last quarter, we presented on some of the data talking about polysubstance use and its association with poor mental health, depression, and the like. And so polysubstance use, we tend to worry about from that standpoint of, having kind of these relationships with greater negative consequences. It can be long lasting. So respondents were adults. These are all kind of adults. We controlled for, as Laura mentioned, sex, race, ethnicity, education level, and age. So we controlled for those things within our analyses. But these are all adults reporting on adverse childhood experiences before the age of 18, and then reporting on their current co and polysubstance use. So in this moment in time, those experiences were related to my current co and polysubstance use. So that's something to kind of take into account, is this can have this long lasting association with substance use. The other is that when individuals endure kind of these multiple adverse childhood experiences, there's concern because there's this kind of buildup cumulative effect. And this is kind of that 4 or more kind of threshold that is kind of being looked at. And so even compared to any particular one experience, this kind of cumulative effect is really what has concerned many from a clinical stance, because it then creates kind of these relationships, associations with these kind of negative kind of impacts on the individual's lives going into emerging adulthood and then further into adulthood. So the discussion around, those that are experiencing these adverse childhood experiences, like from a substance use prevention and intervention kind of aspect, we should be intervening early and often and paying attention when we see some of the adverse childhood experiences. Even just kind of at the level of, okay, divorce, substance use kind of in the home, and like that has that magnitude buildup going into account. So the kind of look at some of the ACEs and how it can help us really kind of think through and start to kind of address how prevention can be tailored in different ways. And so we're hoping to kind of look at some different aspects around different subpopulations. When we start to kind of then slice thinner on the layers, this is where it can be kind of problematic from the level of analyses. And so as Dr. Lowry St. John talked about, some of this is, when you start kind of getting down to slicing some of these based on subpopulation or community level, or like school community level, the layers start to get really kind of thin for numbers. And so then it becomes a little bit more difficult. But we want to look descriptively too at some of this to kind of see what we have and what things might be there. So just a quick acknowledgement. So funding, for what we do comes from SAMHSA, the Strategic Prevention Framework, Partnership for Success, or the SBFPFS, in conjunction with Department of Health and the Alcohol and Drug Abuse Division, so AVAD. So just quick acknowledgement. So thank you, and I'll take any questions that you might have.
Thank you, Laura and Michael. We are going to move on to questions. Please type any questions or comments you have on the presentation, the Q&A feature, or you can raise your hand and I can unmute you. Or if you prefer, you can use the Zoom chat. I think we do have one question right now in the chat.
Yeah, and so Tanya, you had asked about e-cigarettes to the analyses, and we actually did include, and that's why we kind of throw in nicotine and tobacco, because we looked at uses of any nicotine products and kind of delivery. Now, it would be interesting too to kind of look at e-cigarette kind of separately or in kind of conjunction with, so e-cigarettes in conjunction with cannabis and alcohol for the polysubstance use. And that actually is something that plan to do coming up maybe in the next year for a different project. So I'll hopefully have some other data to report out on some of that in that regard. But yeah, because we're seeing that downward trend around tobacco use. So where e-cigarettes and vaping, we're seeing an upward trend with youth. So and also young adults, which is concerning.
I'll just give a few moments to see if anyone's typing any more questions. Okay, so if there's no more questions, thank you again, Dr. Phillips and Laura. We are now, and to Dr. Laurie St. John, we are now going to move on to closing remarks. We are working on updating our SEOW member list. If you have been a previous or are currently a member, you will receive a membership form to ensure that we have an accurate list of members. If you'd like to be a member of our work group, or if you have anyone you'd like to refer, please email us. We will be reaching out to SEOW members and prevention providers to get feedback for topics of interest. Please contact us if you would like to suggest a specific research topic of interest, or if you or your organization would like to present on data you've collected, we would like to schedule you for an upcoming meeting. Our next meeting will be on August 30th at 9 a.m. to 11 a.m., also on Zoom. We would like to ask everyone to please fill out our brief post-webinar survey that will pop up once you exit the Zoom room. We greatly appreciate your feedback on these meetings. If you have any ideas for future speakers who would be willing to share data related to alcohol and substance use, please let us know by sending us an email at m4c+seow@hawaii.edu. We would be more than happy to reach out to anyone you think would be a good fit. So that concludes our SEOW quarterly meeting for June 2023. We'll see you again at our next meeting.